Hey, you're listening to Resilience Radio. I'm Irvin Eisenberg, host of the show and owner of Resilience Occupational Therapy. As always, the opinions on this show do not necessarily reflect my own or Resilience Occupational Therapy's opinions. Everyone's got their own healthcare needs, and a variety of different perspectives are showcased here. Additionally, nothing should be considered medically diagnostic or prescriptive in any way.
Today's guest is Dr. Adrian Lowe. He's a physical therapist and has a PhD in pain neuroscience education. I personally have taken some of his classes and frequently utilize his Why You Hurt pain neuroscience education system with my clients. It's really great to have you here today, Adrian.
No, Irvin, thanks for having me. It's great to be here.
So can you start off the field of pain neuroscience education? Are there many PhDs in it?
There's a lot more than you think. 10, 15, maybe 20 years ago, there was about three of us that always hung out in the same coffee shop and chatted about the same stuff. Well, I don't want to say coffee shop. I think it was more on the other side of the scale, and chatted about this. But now it's getting very exciting. And by the way, it's not just physical therapy; it's occupational therapy, in medicine, and whatever. So, pain neuroscience itself is growing a lot. So that's really cool.
Okay. Yeah, and so you were one of the founding three of this field, would you say, or?
No, not even close. No. There are people way ahead of us. We are, as with anything in this world, we're standing on the shoulders of giants, right? There's people before us. And so there are many names. I mean, I'm always nervous with names because you always say a few names and then you forget somebody and they email you like, wait a minute, you forgot about me. But I mean, people like Louis Gifford, David Butler, Michael Shacklock, Mark Jones, the list goes on. There's a huge group of people that talked about. Just remember, Erwin, evidence-based practice didn't start till the mid-90s, so there was no research really. And pain neuroscience education started as a research part of it. And so there was people early on in that space. I happen to be one of them, but driven by very powerful people ahead of me. I just want to make sure people know that. So I was not a pioneer. I was a very welcoming recipient of very kind people to help me. Yeah.
Okay. So, can you describe what pain neuroscience education is? At least the initial overview for the listeners.
Yeah, it's a simple idea. So just to phrase it or put it in perspective, we have learned so much about the human pain experience in the last 20 to 30 years. I know it sounds silly, but this idea of explosion of how pain works from the brain science studies and the scans and neuroscience, so people understand, we've learned a lot. For the longest time in this world, we've tied the health of your tissues to pain. So if you've got bad tissues, you hurt. If you hurt, you must have bad tissues. We've done that for the last 350 years. And when patients came to us and said, I hurt, we would tell them everything we could about their back, their neck, their knee, their shoulder, their wrist, but never told them anything really about what's happening to them. Tissue health is okay, and it works for most cases, but things like where the nervous system wakes up and becomes sensitized, which you and I may know clinically as things like central sensitization, allodynia, hyperalgesia, those concepts are critical in pain experiences. The fact that your brain gets busy during a pain experience with other things that it's supposed to do, all these things. And pain neuroscience education just takes this incredibly cool new research and puts it in a language where we can take it to a patient and they sit in the clinic with us and go, wow, that makes sense. And now we have this incredible research to show that it makes their lives better for it. Their fear goes down, the catastrophization goes down, they have more hope. They're like, wow, I can be okay. And hurt isn't always now tied to their tissues. I hurt, but I'm going to be okay because it's just my system. It's sensitive. Sorry, it's not a short answer you wanted, but
no, that's fine.
It's just teaching people about the new science of what we've learned about pain, and it makes their lives better. Yeah.
Yeah. So it's the lack of as strong link between tissue health and our pain experience is a large part of what you're talking about.
Yeah, and we need to be careful, right? If you today sprain your ankle, more than likely your ankle is a reason for your pain experience, and that's fine. But especially with persistent pain, if you and I hop on another podcast a year from now, we chat and you say, even my ankle still hurts. That doesn't make biological sense if you only tie to tissues. Tissues heal, right? And why does Urban still hurt today? Because there's been a sensitization. So it definitely was designed for people with more persistent pain, but now we're doing it in acute pain, perioperative, etc. But yeah, you're right. It's a little bit of a moving people away from only tissues as a source of pain.
So I've worked with a lot of clients trying to do some teaching of the pain neuroscience. And often we come to this sort of rut where they might start to be cognitively understanding the material. But then there becomes the question of, okay, well, how much of my pain is being sort of just in my head? And I know that's a whole thing to unpack. But also, How do I know what a real warning sign is that when there really is something wrong, if the brain and the central nervous system is what's giving it to all of us? How do we know when there's something really wrong versus when we're just catastrophizing?
Yeah, well, there's a lot in that question. Well, first of all pain is real. I need people to understand that. We've never scanned fake pain. And if we look at our brain scan studies, all pain is real. Pain is a very interesting thing because my pain is not your pain is not my pain. We have different experiences. In medicine, we ask people their pain rating, and they say my pain is 7 out of 10. I have no other way in this world to validate that that's a 7, or is it a 6, or an 8, or a 3, or a 5. No way. It's your subjective expression of how something is impacting your life. Now, going forward to what you were saying, very often we will teach people about pain and they will jump to that, oh, you think it's in my head, which means it's not real. Well, first of all pain is real. That idea of jumping to the, oh, you think it's in my head, unfortunately comes from the old Cartesian models of pain in the Renaissance period, where it was either in your tissues real or in your brain it's not real. All pain is real. We need to understand that. On a clinical level, for a clinician, to get a patient to, for a lack of a better term, not jump there and go, oh, you think it's in my head, which means it's not real, which means you don't trust me, and it just, that whole relationship goes sideways. First of all, when we teach people about pain, we don't typically bring the brain into it early on. If I have a patient at visit 1 or 2, I don't know you, you don't know me, so I'm not going to say, hey, let me tell you about your brain today. That's not going to work. We talk about, your ankle and your back and your neck and your knee and your shoulder, and slowly creep towards the brain, so that if by visit 4 or 5 or 6, when I get to know you really well, say, hey, Erwin, thanks for coming in today. Today we are going to talk about something very important. And we are going to talk about your brain, because your brain is in your head. But if at any point you and I have this conversation, then you jump to the, oh, you think it's in my head, I want you to know all pain is real. But if I kick you in your leg, it's your brain that's going to say, Adrian's a jerk, call the lawyer, right? So our brain must be part of it. So what I'm saying is, Erwin, we preempt it. Before the patient can even jump there, I've already covered it, so it's off the table. Mm-hmm. So, but we will talk about the brain, we'll talk about pain, and your brain is very powerful when it comes to pain. And we can have an injury with no pain, or pain with no injury, so the brain must be a piece of it. But that's typically what go. But I think the biggest mistake clinicians make, they get excited. We stand at conferences, we do these big presentations, cool brain scans on the slides, and people run to the clinic and say, let me tell you about your brain, and then people freak out because that whole dualistic model is so embedded still in society for us. But I think a patient that can see a clinician that cares, I really care about you, I want you to be here, I'm here for you to make your life better, they will trust you a little bit more. And then if you do go there, it's very unlikely they will, I think it's in my head, you don't believe me, I'm going to call your boss and storm out. That happened years ago because we weren't very good at this yet. But it's a very important part. The other part of the conversation, catastrophization, those things, they're powerful. I mean, fear avoidance, catastrophization, depression, these are powerful modulators of pain, but they're also very real. They're very, very real. We all catastrophize, right? Oh, my goodness, my iPhone is almost dead. I just catastrophized, right? It's part of life, but if it starts impacting your pain, it means it's something that I have to deal with, as well as your shoulder and your knee and your back, or whatever it may be.
So I guess as people, if you've got somebody who isn't necessarily pushing back and understands when we're saying that the all pain experiences are in our heads, that's where we process them and have the experience. And when people cognitively get that, but there's still they're having pain in their body. They've had it for a while. They're still worried about it, but they don't seem to have, if we were to look at like the centralized sensitivity inventory, they don't seem to be high on that score. How do you tease out when it is a mechanical tissue problem that needs further addressing versus when it's a central nervous system overactivity or sort of a mindset around it? How do you tease out that clinically?
Yeah, well, first of all, I'm really happy you're asking this question. It's the right question to ask because I'm a physical therapist by training, right? You're an occupational therapist. People in the physical realm do physicals, are physical therapists, occupational physicians, whatever. We have no business going to the cognitive route if we haven't done our due diligence to check you out. If you walk to my clinic tomorrow, I have to check you out to make sure everything does check out. If I find anything that doesn't make sense based on my training, then I need to refer you to the doctor. I need to get an x-ray. I need to do the right thing. It's only when those things check out and you still hurt. I checked your knee and everything looks okay. The ligaments look okay. The meniscus look okay. The range of motion, everything checks out. But Irwin says, I still hurt. Then we get to the point of understanding that, hey, you may not have a knee problem, but you may have a pain problem. Those are two different things.
Yeah.
But again, I'm glad you asked it, Irvin, because the first rule of medicine is obviously do no harm. So many people get excited about this stuff, and they start to talk to people. You have no business. I have to make sure your knee's okay, your back is okay. How is that blood pressure working out? How is your, all those things I have to check. That's why we do review of systems, all these things. And if everything checks out, then I can go there. Then it makes total sense. So it kind of brings back to the one question you asked earlier about, when does pain actually tell you that something's wrong? Well, it's typically those acute episodes, right? Irwin fell off his bicycle and the femur's going that way. It's supposed to not go that way. Those are simple things. We check you out, get you to the emergency room. We need to get that leg taken care of. Acute pain is a brilliant thing. It's there to protect us. Without pain, you'd be in trouble. So, guys, when pain persists beyond its normal phase of healing or really starts impacting your life and everything else checks out, that's when we kind of go there. Because typically in those cases, that's where the nervous system starts ramping more to protect it. Because your brain doesn't know what's going on. I've seen 7 therapists, 3 chiropractors, I've had MRIs, nothing's getting better. And that system starts waiting to protect you until it can figure out what's going on with me. I don't know what's going on.
Okay. So I'm sort of wearing 2 hats as the person interviewing here today. I'm realizing I'm a sort of eager student of yours, as well as trying to make sure that we get your as well as the host of the show, and wanting to make sure that people get understand what you're saying. I want to make sure we're not getting into too high level clinical end of things, but want to head in the direction of, if you could get one message across to sort of everyone about pain, sort of, what do you wish was taught in every school and was sort of just in the general public mindset about pain?
Those are 2 different things, right? I mean, as we travel around the country to PT school, OT school, medical school, PA, nursing practitioner, there is a very definite message we want to get to healthcare providers. But then on the flip side, the real message is to the clients, is to our patients, is to society in general. If I had to think of one that has to span both of them, I think, Erwin, it would be the idea of a sensitized nervous system. If you walked out of your building, your school, wherever you are today, and you sprain your ankle, you will likely hurt some tissues. They sprain, they strain, just like they all happen. The tissues heal, but your nervous system will actually start ramping up to protect you. It'll tell you, hey, it ramps up, protects it, go to the emergency room, the only doctor, go to therapy. Most people, the nervous system will then calm down and say, my job is done. Awesome. I got Irwin's attention and he went to the emergency room. But in some people, about 1 in 5 people, the nervous system will ramp up, but never calm down. And now you keep feeling your ankle, and you start getting worried and nervous and anxious, and that makes it even worse. So this idea of a sensitized nervous system is, I think, if more people understood that, like, you know what, yeah, I did hurt my ankle, it's getting better, it's still sensitive, but it's okay. It doesn't mean there's something wrong. It just means it's still sensitive, right? That, I think, is a huge step in the right direction. I mean, Pfizer is spending billions of dollars on drugs to calm your nervous system down, right? Some Volta, Lyric, and Iran, from all those big membrane stabilizing drugs. It's well understood, but if people can understand it, sensitivity is a normal thing, and you don't have to freak out about it. Don't have to run off and get another X-ray. Just keep it moving. Over time, the system can dampen down as well.
So when we're talking about people being hypersensitized, we're discussing this in terms of pain, but there seems to be a strong parallel when you're talking about anxiety or just fears in general, even if it isn't a pain experience in the brain. I'm guessing it's a little more outside of your specific field of expertise, but could you speak to that parallel to other types of sensitivities?
Oh, absolutely. I mean, just so we understand, I mean, right now, a lot of our work in pain neuroscience has tied pain strongly to fear and fear avoidance. Pain and pain catastrophization and depression, those are the three big ones out there. Pain and depression is a chicken and egg. Or if you develop chronic pain, you're going to become depressed. You're going to feel bad about yourself and down. On the flip side, if you develop depression, the chance of chronic pain is very similar. You can literally argue in both directions. The psychosocial variables are just as powerful as the pain. And for too long, again, you kept your tissues away from the brain and your psychosocial variables. They all work together. So they're very powerful. But your sensitivity to other things change. Pain is only one way the brain will protect you. It can protect you lots of other ways, from your GI system to motor control changes to immune function. Your whole system can change. We always talk about pain as the metaphor is a lion. If a lion jumps in the room, right, we shunt blood to areas we need it. We run out of the room, we punch Adrian, push it in front of the lion, and get away from the lion. But living in pain every day is kind of this lion that's in your life. And one way to protect you is pain will protect you, but also there's linguistic, there is motor, there's respiratory. We can now actually go way wider. We can start talking about fatigue. We can talk about sleep. We can talk about GI problems. The list goes on. Immune functions. If you look at the current listing of all these syndromes and all these labels that people get attached to them, they're big manifestations of multiple systems that's trying to protect you. Pain's only one. The interesting thing is, as we're sitting here, I get invited now to speak to a lot of professional sports teams, NFL, NBA, Major League Baseball, because sports performance is also an output of the brain, just like pain. And if your brain gets busy, your nervous system gets busy, what suffers? Well, sports performance. If your brain and your nervous system gets busy, it can produce pain to protect you. And so it's really interesting. It's only one of it is pain. We just happen to focus on that right now. So.
Okay, so these systems are all running in parallel, and you have things like chronic fatigue syndromes and anxiety disorders that are essentially the same mechanisms as far as not exactly necessarily, but as far as the body protecting itself. But your focus primarily is the pain response.
Correct. Absolutely. You just nailed it. There's a stressor. Something stresses you right now. It can be injury, accident, surgery, work, life, whatever it is. And your brain and nervous system ramps up to protect you and uses different systems to protect you. Pain is one of them. You're correct. Could be other ones as well. And that's why these are all biological systems. Now, why in one person is it pain? Why in the other one is it endocrine? Why in the other one is it immune? Those are some big conversations that'll take a long time to discuss, but a lot of theories, but yeah.
So I often encounter people who make reference to their threshold for pain. Either they have a high threshold for pain or a low threshold for pain. It seems a bit binary for me. There's often talks of, and I, as a cisgender male, I'm not going to be having the experience of giving childbirth, so I'll tread carefully with that. But it seems like every pain experience is so unique. Not at all to downplay the experience of childbirth, but there's a lot of additional hormones involved, and there's the memory of pain involved in that as well, which so that it is not a traumatizing event in many cases. But I feel like I encounter some people who in some aspects have a high threshold for pain, and in other aspects don't. And it may be that they were in a car accident, and in general, this is someone who's a farmer who can work all day and even if their shoulder's bothering them a little bit, it's not that big of a deal for them. They stretch a little bit and move on. But then they get in a car and now their neck hurts because they turn too far one direction. And it seems very situational how sensitive someone is to pain. I was wondering if you could speak to that a little bit.
Well, first of all, I want you listeners to know you went there when it came to childbirth, not me. I'm not touching this one today. This is on you. So, first of all, you're correct. Everybody's pain is different, right? So we need to be very careful of generalizations. But epidemiological data and research have shown us there are patterns out there that we do see, Erwin. There are people with higher thresholds for pain, lower thresholds for pain. By the way, cultures are very different in pain. You can either be stoic or expressive. Americans are very stoic. Suck it up. Stiff upper lip. Walk it off. Come on. Get over it. Where some other cultures are more expressive. It doesn't make it right or wrong. It just makes it more different. By the way, you adapt to the culture you move to. So if you move out of Vermont and open up the Irwin's clinic in, Barcelona, and you find yourself in a Mediterranean culture, people are way more expressive. So you will actually become more expressive. It's part of your shift. I am going to go there because you started this, but men and women experience pain very different. And that is for thermal pain, mechanical pain, coping skills. So yeah, there's huge differences. There's genetic links. I mean, people always ask me, is the thing about, redheads and people that are fair true? Are they more sensitive? There are genetic links to some of these things, no doubt about it. I'm just always worried about generalities because we're very different. But the part that I really like is if you look at the research, people that when they hurt themselves focus on their pain, they really focus on it. Their trajectory is very poor. But people that hurt themselves and focus on what they get to do, the function part, they do really well. These are the farmers that I don't have time for pain. I got to keep working, whatever. But like I said, if that farmer finds himself in a different scenario where he's now done with harvesting and he sits down and, for a lack of a better term, think about it, he may notice something, whatever. But there's a lot of cool things. This is what I know I'm a pain nerd. I get it. But there's so many cool things about pain that makes your pain different than mine. But we are different. We're very different. Yeah.
So I guess one thing I wonder about from what you're saying is you've got somebody who tends to push through their pain, either a culture of stoicism or not feeling safe expressing it, whatever it may be. When is that at what point is that no longer a healthy characteristic where you're ignoring your pain and you're ignoring all the warning signs, so serious injury might be taking place? And when is it good to push through?
So again, you're not having a long conversation. You and I should go sit down and it's so hard, right? The reality is, yes, there are people out there that are so hyper-focused on what they need to get done, they forget about the fact that they just broke their leg or they just had this and this and this. There are very different warning signs, right? Acute pain, pain tied to trauma, injuries, accidents, surgeries. That's absolutely well known. I would probably say, if you ignore pain and you're pushing through it, but it doesn't have a positive effect. It actually just keeps getting you in a negative spot. More pain and more pain and more pain, especially after the fact. Those are things that we probably frown upon, like, this is not a healthy behavior. The idea of pushing through some pain to get the harvest done, or pushing through some pain to get some work done, and then afterwards you're okay, but you got the work done, you accomplished something, that's okay, and the pain goes away or eases after a slight flare. It's typically the behavior of that pain, Erwin, that we need to be careful with. But if it just keeps spiraling you down and down and down and down, we see it in athletes. Athletes come to us, and for them it's no pain, no gain, and they can actually destroy themselves by not listening to their bodies. There's a healthy idea of pushing into pain to recover, to get better, to get back. But if you push it to where it's detrimental, physically or psychologically, then I think we're getting into probably a very negative behavioral aspect we have to deal with.
Yeah, so like most things, there's a balance, that there's a benefit to being someone who becomes very functional oriented, and because they can do something, they will continue to go forward and do that, and they sort of put the pain on the back burner, and because of that, they might be experiencing less pain and have less chronic pain conditions. But on the other end, if they push too hard, then they may be actually damaging tissue, and it's sort of being a bit more obtuse to their experience.
Absolutely.
So I just want to make sure, because we had sort of brushed on, and we were talking about the differences, genetic differences, be it gender-based or REDS, and the people who have high or low pain thresholds. And you were talking about different types you were talking about temperature versus pressure and different types of pain responses. Is it your experience or your understanding that people may have a high threshold for certain types of pain but not others?
Correct. And that's been proven, yes. Some people have more mechanical sensitivity, but not as much thermal or other ways around. That stuff has been proven significantly in the literature, yeah.
So one thing when people are talking about the brain's power and our pain experience and sort of the manifesting your own reality to some degree, is this sort of gets into placebo studies. And I'd be curious sort of if you could speak to placebo as it relates to your research.
Yeah, I think one of the biggest travesties in the world is that people always think that placebo is fake, right? One person gets a real treatment, the other person gets a fake tablet, and the fake tablet is, just as effective, those kind of things. I think what I need your listeners to understand for today is placebo is a very fancy term for our brain turning on its own chemistry, its own happy chemicals, enkephalins, endorphins, serotonins, that eases our pain. Actually, to be honest, Erwin, the biggest shifts we've seen in human pain experiences in all research comes from placebo research. What it means is if we can tap into the brain's ability to control a pain experience, that's huge. And placebo happens every day. You go to the doctor, you go to the therapist with the expectation of helping or getting some help or getting better. That's placebo. The expectation, and the opposite is nocebo. If you think, I'm going to see Erwin, there's no way he's going to help me, he's not that smart. That's negative, right? That's nocebo. You can actually, the brain's chemicals, there's a quote out there that our brain produces opioids that's 50 times stronger than what you can get in the emergency room. Now, I'm not 100% sure about that, but there's some seriously good research in that area, because during catastrophic events, our brain can shut down pain, right? You chop your leg off or you're being shot, and you can get past that to get to the emergency room. And the brain's ability to turn that on or off is really where placebo, nocebo sits. And the really good clinician can actually enhance placebo. It's to build that expectation when they come to you and, you know what, I'm going to go see Adrian. He's really good and I know he can help me. So much so that I'll drive by 4 other therapists who will see him. That's the expectations, right? And how do you get that? It's you're good at your craft. You do your thing well, and you do all this cool stuff. I always tell the students, you're a modern, new age, biopsychosocial pain-informed therapist. You know what's going on, and you're not afraid to go there. So all those things drive placebo. But I want to make sure that people understand it's not just you got to be good. You got to be technically good at your craft. If you're a physician, if you're a PT, an OT, or whatever, be good. It matters. The studies show us that because people veer to those clinicians that they trust and they're good at their craft. And that fosters in the brain's chemistry to change, which we can measure very easily, actually, in research. But placebo stuff is super cool. It just tells us how cool the brain is. The brain controls our pain experiences.
I wish I knew what this study was, but I remembered hearing about a study that was studying placebo, and there was 3 different groups. One was the group given whatever the medication was that was being tested. One was given the placebo and wasn't sure which they were getting. And then the third was given the placebo and told it was the placebo.
Yeah.
and it's my recollection, and I'm guessing you've looked at way more studies than me, so I'm happy to have this completely saying, hey, this is not an accurate thing, but that both placebo groups had the same degree of positive effects.
Yeah. Even if you know you're getting a placebo, which should negate that, it still works. I mean, it is shocking. You know what's really interesting for me, Erwin, is when we do studies, placebo-controlled trials, where one group gets this, the other group is placebo, and you tell people ahead of time you have a 50% shot of getting it. A, they sign up for the study, which that's like, wow. B, they know they could be getting it, and they still do better. That is just absolutely fascinating for me if you look at the research. But that's kind of what the study you're talking about. I've seen those kind of studies. People that get a placebo know they got the placebo and they're better.
So my
Isn't it?
my personal takeaway from that is that what is the preventing? They're getting a ritual of taking a pill. They're probably checking in with a clinician regularly, so they're feeling taken care of, and there's a process they're going through. So I let my ethics of not wanting to lie to my clients. This sort of validates I don't need to lie to you about things in order to get the positive placebo effect. I just need to be present with you, go through useful ritual, and it's not about trickery.
You should never need to lie to a patient. That is, I cannot. But the reality is, no, you said it perfectly, Erwin. You just need to be there, pay attention, care. You know, one of my favorite quotes is Eisenhower's quote, where he said, "People don't care how much you know until they know how much you care." So when I work with residents and, they're early in their career, they're really stressing out, I teach them pain science, and they're like, "Adrian, what happens if I'm in a clinic with a patient with chronic pain? I have no idea what to do with them." I said, just be there.
Easy.
And put your pen down, look them in the eyes and say, "Tell me your story. How can I help you today? How can I use this 40, 45 minutes to make your day better today?" That is what that is. And we can now measure the neuroscience behind it. The brain lights up, all the cool stuff, that human connection. Very, very cool. I mean, I'm glad you brought it up because it is a critical element of healthcare, if you will.
So the pain stuff has been around for, well, the understanding of it to some degree. It's sort of really, the pain neuroscience education is really awesome. I have, and this is sort of a book that I feel like you find at almost any self-help or new agey book sale, and I've had people swear by it, including my mother, who has been helped quite a bit by it. But I'm curious your opinions on. Are you familiar with this?
Sorry, I'm trying to see. Oh, Dr. Sarno's book.
Yeah, Sarno's The Healing Back Pain. It seems like he was kind of ahead of his time to some degree.
Well, wait a minute. Well, first of all, we never argue with Mom. Mom is always right. The second thing is, Dr. Sarno's stuff is very well. I mean, I want to be very careful. He had a huge following, especially in New York, East Coast side, hugely. When the first time Sarno's stuff came out, and it was in 60 Minutes and 2020 and all those kind of things, I think you're right to an extent, Erwin. He was probably ahead of his time. Now, he was lucky because he's a physician. He's got the white lab coat experience, all those kind of things and whatever. But he, the more I study pain, the more you're kind of like, wait, things work. And if you really follow the stuff he was doing, he did some cool stuff ahead of his time. So I had no issues with what he was doing, per se. No, you're right. He was ahead of his time. Huge following, a lot of people reading his stuff. I could probably find people that said, that didn't work, but that ties into the bigger conversation you and I have had today. I got patients that hate my guts, and I got patients that can end up coolest since sliced bread. And that's just part of this journey of being on pain and getting a provider that's helping you, or today makes sense to you, right? It's amazing. So,
yeah. My mother's story with reading The Healing Back Pain from Dr. Sarno's was that she used to have debilitating back pain that would come periodically. I would say that our microculture, back pain was an outlet of acceptable pain in our household. So that was sort of.
Yep.
My father had a legitimate injury, and then we all sort of would mirror that when we were under stress. But in any case, my mother would have back pain, and she'd be like, "Oh, I feel it coming. My back's gone out," and then she would pretty much lay down for a few days, and she'd protect her back, and everything would seize up. After reading Dr. Sarno's book, she went, "Oh, I'm starting to feel the symptoms of back pain. I'm going to go stack some firewood." Very slowly and carefully, but I'm going to keep moving, and I'm going to be careful of what's going on, and I'm not going to lay down and give up. And her back would hurt for a few days, but it never really stopped her function. And that seems to go right in line with what you're teaching.
Absolutely. I mean, if somebody just take that little clip you just did and you start analyzing it, I showed it to my residents right now, they would say things like, we're talking about fear avoidance, we're talking about catastrophization, we're talking about pacing and graded exposure, all those things. And those are beautiful strategies of part of the pain neuroscience paradigm. Absolutely. So you're right. He did it way before, but they just didn't call it that per se. But very cool stuff. Yeah. Wonderful.
So, do you have any other gems you'd like to share with listeners?
Oh goodness. Yeah. I mean, there's so many cool things. I mean, the bottom line is just, Urban, if the more people learn about pain, be it if you're a provider or you're a patient, the better off you are for it. On the clinical side, the more you learn about pain, the clinical practice actually becomes a little easier and dare I say it, fun. I was an orthopedic manual therapist, very orthopedic, joint muscles kind of based. And I struggled with helping people with persistent pain, but the more I learned about it, the more the clinic became a little bit, I don't want to say fun. There's nothing fun about this. This is a very real thing, but I wasn't as stressed about it. I could try and help what I could. I knew my limitations. So on the clinical side, the more you learn about pain, the better clinical practice becomes, because the reality is 1 in 5 Americans are hurting right now really bad. If you do the math, that's 80 to 90 million Americans. For a lack of a better term, you're not going to get away from them. They're going to come in, so you have to know what to do with them. On the patient and the society side, the cool thing is the more you learn about pain, the better off your life is for it. You don't freak out about it. You're more willing to move, and these are all good things. Just as we heard from your mom, right? Don't worry about it. Let's keep moving. Let's go do our thing a little bit, but often. So there's a lot of good reasons to learn about pain and why it's a cool thing for us as society, be it a healthcare provider or a patient or just somebody at large. I think it's really cool. But yeah, as far as sharing it, I can probably spend all day talking about different things, but yeah.
Well, thank you so much for coming on today. I really appreciate your time and clearing up some of those things for me.
I don't know. I maybe have added to some of the confusion, but thanks for having me. It was nice to meet you and appreciate the opportunity.
That was Adrian Lowe, and this is Resilience Radio. If you enjoyed this conversation about pain neuroscience and pain, I recommend staying tuned for next week when we further discussion. I have a conversation with a social worker regarding their clinic and their practice and philosophy in dealing with people with pain. The music was brought to you by Aaron Marcus with their tune Some Biological Process. Until next week, take care.